So it's a great honor to be presenting to you today, and I thank our moderators. It's been a pretty good conference in terms of pancreatic disease and where we're going. And as Dr. Martin said, today is a little bit going to some of the extremes, especially in the treatment of locally advanced pancreatic cancer. I have nothing to disclose. So what I want to do is really begin by saying some realistic objectives of what we should be trying to achieve with the management of locally advanced, talk a little bit about outcomes with radiofrequency ablation of locally advanced cancer, as well as irreversible electroporation. And at the end, kind of come around to where we've always known is that is surgery maybe the best and operating the best option, and should we not consider ablation? And then concluding. So we all know if 10 people walk into our office, 5 of them at the outset will be unresectable, they'll have metastatic disease. 2 of them will be able to bring right to the operating room, but it's this 3 or 4 people in between that we don't really know what to do with. These are our locally advanced patients, our kind of extreme, borderline, bordering on locally advanced pancreatic cancer. And these are the patients that we need to try to get into the resectable range because this is the only option of improving the survivability of this disease at this point. Without surgery, with our best systemic therapies, our median survival is in the range to 8 to 13 months. And we know in this room, obviously, that operative management offers the best odds of extended survival when it's possible. Locally advanced pancreatic cancer is the pain in the neck that is unresectable. What I mean by this is that whether you go by NCCN guidelines or the international consensus guidelines, they always distribute it between whether it's a head lesion or whether it's a body lesion, but when you're dealing with a locally advanced pancreatic cancer, you're really dealing with a neck lesion. It's involving the arterial and venous vasculature, and this is really where our problem is. And historically, by all guidelines, this has been considered unresectable disease. But as we've seen throughout these presentations during the last few days, and as we're seeing more and more in the literature, we're moving away from a definition of these being unresectable. We're looking for the patients within this group that are resectable. And obviously the Heidelberg Experience session yesterday, presented by our moderator, went over some of these issues. So what about survival with surgery for locally advanced pancreatic cancer? There's been 2 randomized studies that looked at palliative chemotherapy versus surgery. These were finished in 2004 and 2008, so in a whole different era of chemotherapy than we currently have. And what they show is that 40% of the patients who underwent surgery were alive at 3 years, whereas none of the patients who had palliative chemotherapy were alive at 2 years. So this was early studies, bad chemotherapy, relatively speaking, but the patients who did undergo resection did considerably better. So what is our rationale for operative management? Firstly, the imaging that we currently have, our best cross-sectional imaging, has very poor specificity in terms of determining what's tumor and what's desmoplasia. And this is especially true in pancreatic tumors, which are so desmoplastic. The AHPBA, the American College of Radiology have all come out confirming this point that imaging is not good. Mass General's presented a paper that you can't even really use imaging in the modern era of FOLFIRINOX. This is no surprise to anybody in the room. And we've entered a new era of chemotherapy, what was once the modern era of colorectal chemotherapy that gave rise to more advanced and more aggressive approaches to liver mets. I hope that we're entering that era now with our either FOLFIRINOX or gemabraxane, these combinations of chemotherapies that are really changing the landscape for treating this disease. And the third rationale is this ablative therapies have shown some therapeutic benefit, and that's really what most of the focus of today is going to be, but either for primary treatment of a tumor in situ, you're not removing the tumor, or as a margin extension, using ablation to extend your margin has shown benefit. This is all, of course, building on the heels of much better perioperative safety, multimodal therapy, and better selection of patients overall. So this is a Memorial's experience in which showed that over 3 decades, over about 25 years, about 1,200 pancreas operations, very little progress was made in median overall survival, 23 to about 24 and a half months over these 3 decades. But what did change over this period was the amount of people who passed in the first year. So this is an issue of selecting the right patients, again, improved perioperative care, and better chemotherapies, although looking, in the early 2000s, it was still basically a 5-FU or a gemcitabine-based chemotherapy, nothing compared to what we had now. But what this paper really shows is that where most of our improvement has been made is in the first year of care. Everything else has not changed over time. For borderline disease, you could look at all different studies. They'll show all different things. This is from the recent ASCO meeting, and basically showed a median overall survival of 11 to about 26 months in borderline patients receiving FOLFIRINOX. So best systemic therapy, still with surgery. Most of these patients went to surgery, still looking, though, on an average of about 25 months of median survival. In terms of borderline, locally advanced cancer, I like the LAP07 trial. One, it's a well-done trial with chemoradiotherapy and chemotherapy at first, and then a second randomization to chemoradiotherapy. What I especially like about this trial when we're trying to set our rationale for operating on locally advanced pancreatic cancer is that everybody always criticizes, and somewhat rightly so, our ablative papers as these are being highly selected patients. But in the LAP07 trial, these were highly selected patients that got on to the second randomization. If you look at patients who didn't make it to the first randomization, their median overall survival was 7.7 months. But the patients who then went on to continued chemotherapy and chemoradiotherapy, they had a median survival of almost double the time. So these were selected patients as well. So if we put all this data together, what we're trying to achieve if we're going to be operating on locally advanced pancreatic cancer is a median survival about 15 to 24 months. That gives us the range of what we're finding with patients with locally advanced through all comers. We want to perform operations with comparable morbidity and mortality to what we expect for resectable or borderline resectable cases. And what we want to try to do is eliminate the indefinite palliative chemotherapy that patients need after their operation, after their therapy. We don't want them on therapy for the rest of their lives and then saying that the ablative therapy was the beneficial aspect of what allowed these patients to live longer. So as we all know in this room, the ablation's been used in many solid organs. The big limitation is that the heat with most of the ablation techniques generated causes damage to vital structures. You could use it in the liver, you could use it in the kidney, but when you start dealing with areas around the pancreas, you're dealing with a whole different environment. The crossroads of the digestive system, as I like to say, where you have all of your blood supply to and from your digestive tract. You have your enteric contents moving through, your enzymes coming through ducts. It's not an easy place to ablate with a thermal. The studies have suggested that the ablative therapies are relatively safe and could contribute to local control, but there's been no randomized clinical trials of any of these therapies compared to best systemic treatment. And I think that's critical because, as I keep making the point, our whole environment of systemic therapy has changed rapidly recently. So this is a nice little chart. I personally do not consider SBRT a ablative therapy. It's not enough radiation to really be ablative. But this little chart gives a view of where RFA and IRE are in terms of number of patients and median overall survival. And you see it's falling in the range of what we want. We want a median overall survival, we said, in locally advanced pancreatic cancer of about 15 to 25 months, and the red squares and the green circles fall in that range. So the most commonly studied forms of thermal ablation have been radiofrequency, a little bit less so microwave. Other forms of ablation, as I mentioned, some people consider SBRT, high-frequency ultrasound, radioactive iodine. But the most common are RFA and microwave ablation. And these cause coagulative necrosis. But as we know, they're limited by the amount of heat. And that's where IRE came in, really pioneered by Dr. Martin. And what it shows is that what it does is it alters the properties of the membrane of the cell, and that leads to inflammation, apoptosis, and cell death using electricity as opposed to pure thermal energy. So looking at overall survival in radiofrequency ablation, there have been 5 studies on this, most coming from the Verona group. And they've shown a median survival of 5 to 25.6 months. There's been a range in the criteria for entry into the studies, of course. There's been different uses of adjuvant, neoadjuvant, radiation, no radiation, intraarterial chemotherapy, lots of range. And 2 studies reported improved postoperative pain relief, which was important because the real view behind the ablative therapies with radiofrequency ablation was really to palliate symptom control and not so much to extend survival. That wasn't the initial goal of it. In terms of morbidity, the range has been 4 to 22%. Mortality has been anywhere from 0 to a high of 11%. But what they did find is that the rates decreased significantly with with experience. And that was really with a change in temperature of changing down to a maximum temperature of 90 degrees centigrade. So this is one of the biggest studies. This is by Professor Bassi's group, and they looked at 100 patients over 3 years. The median overall survival was 20 months, and they had a decreased 30-day mortality of 3% after their initial experience in decreasing their temperatures. What is important to look at is the complications, because these are similar complications that we see and that have been kind of the Achilles heel of IRE, but these portal vein thromboses and these duodenal penetrating ulcers that are really difficult to control and salvage the patients once they occur. The lessons learned was to decrease the temperature, but also that you could not ablate, obviously, the entire tumor. You had to leave a rim of viable tissue that would then be the target of adjuvant therapies after, because in order to ablate without causing severe complications, they had to leave a margin of tumor. So were our objectives met with RFA? We achieved the median survival. That was our goal. The complication rate was plus or minus, and we were unable to eliminate that indefinite therapy. They needed therapy continually after. And this is where IRE kind of came in, and where the view that instead of using thermal energy, by using electroporation, by using electric current, that you could get around vessels, around ducts. And because, in theory, thermal energy was not being generated, then you could destroy the entire tumor as opposed to just trying to destroy the majority of the tumor, but knowing that you were leaving a rim of tumor around. In the studies that have been done, there's been about more than a dozen studies right now that have looked at overall survival, 10 to 25 months. Local failure during a wide range of observation periods have been to about 6 to 28%, meaning local recurrence. Excuse me. And the percutaneous routes have reported lower median overall survival and lower complications. I may get shunned away if there are any radiologists in the room. I personally do not believe there's a role for IRE and a percutaneous route. Anybody who's done this knows how difficult it is to place the probes, and to do so percutaneously seems almost impossible to me. And this may be why their complication rates and their median overall survival have been lower than that of when they're doing in situ management. That's open to criticism and discussion. In terms of morbidity rates, they range from 0 to 57%. Mortality rates have been relatively low. My group had the highest mortality rate of 11% that we reported previously. Otherwise, it's been in the 2 to 3% mortality range. This is the largest series yet presented. This is Dr. Martin and collaborators from 6 different institutions. And what they found was with resection with IRE, that means that you're using IRE for margin extension, and in situ, that the median overall survival was almost 25 months in this patient population. 100% of the patients received neoadjuvant chemotherapy, and nearly 50% received neoadjuvant radiotherapy before undergoing their procedures. In contrast to my data, which I'll be presenting in a second, in the resection IRE, these made up about 25% of this population, and in situ treatment made up about 75%. We're actually a flip in terms of those numbers. In terms of the grade 3 to 5 complications, 24%. The most severe ones were, again, issues related to thromboses of the vessels or these ulcers, although much lower in this series than in our experience. These are similar complications that we see with RFA, which makes you think that there may be more of a thermal effect than we think there is. And this could be a consequence of the consistency of the fibrotic pancreatic tumor that we're dealing with in these situations that have already undergone the desmoplasia from the tumor, but also are now undergoing chemotherapy, undergoing radiation, and you're dealing with a very different environment where it's hard to conduct electricity cleanly between the probes, and this may lead to a thermal effect. So our initial experience, 90-day morbidity and mortality with our first 50 patients. 50 patients underwent 53 procedures. 98% had neoadjuvant, 83 had radiation therapy, 6 died within 90 days of the procedure, and 19%, 10 patients suffered grade 3 to 4 major morbidity. We kind of came out with a much higher morbidity and mortality than other groups had presented. There are a number of theories behind this, although we can't really explain in full detail why we had such a bad outcome. But our survival outcomes were interesting, and this is just one example. This is a patient who originally came to us in the spring of 2012, was already on chemotherapy for nearly a year, and what you see here on the first 2 slides is total encasement of your SMA and your celiac axis with tumor. No question, a locally advanced pancreatic tumor. It was in the neck. The portal vein was pretty well preserved, but unresectable tumor. Underwent in situ IRE in the summer of 2012. This is over a year later. I'm trying to show the calcifications in the aorta here to prove that this is the same patient throughout. 2 years later, still no PET avidity. Excuse me. About close to 5 years later, starting to see some increased avidity over here. And then we see over here that that this is when the patient had recurrence. So the patient basically spent 5 years off of systemic therapy before they had recurrence and had to be treated. This is our most recent data on 96 patients, median overall survival of 24.4 months. We're still hung by our early mortality, so we've had 1 patient loss since our initial series, but it's still 8% because of the earlier experience. And our 3 and 4 complications remain pretty stable. The Impala trial was looking at locally advanced patients that were either going to go to surgery after neoadjuvant therapy and receive IRE if surgery wasn't possible. Limitation of this study was a very small number of people made it to the operating room. And what they found were high complication rates, but really no real benefit with the median overall survival for the patients who underwent irreversible electroporation versus no therapy, no surgical therapy at all. So are our objectives met with IRE? Yes, we are able to achieve a median overall survival of 15 to 24 months. It's questionable whether there's decreased or equal morbidity and mortality to resectable or borderline disease operations, but we are able to eliminate the indefinite palliative systemic therapy and improve quality of life. So this brings up the question based on a lot of different findings, a lot of different presentations that you've heard since you've been here, the Impala trial, but whether we should just be resecting these patients without doing any form of ablation. So this was a study that we published earlier this year. About 61% of the patients had Whipple-type procedures, 21% had distal, a few other procedures. All patients had neoadjuvant and chemotherapy, and all patients were brought to the operating room with the intent of doing IRE. But what we found when we studied the pathology is that 80% of these patients had negative margins, and we would expect looking at their imaging, we would expect 100% of these patients to have positive margins, but only 20% had positive margins. Our distance in millimeters was 3.5 millimeters. What was also interesting was our node count, where we usually expect 70 to 80% positive nodes, was 26%, and pretty low lymphovascular and perineural invasion as well. So in conclusion, RFA is an effective ablative technique. It does require ongoing therapy. It can add to local disease-free survival, but whether our overall survival is impacted remains unclear. IRE is suggested to be an effective ablative technique. We still need a lot more information about it. It does not require ongoing therapy. Again, it adds to the local disease-free survival. Whether it impacts the overall survival more so than the neoadjuvant chemotherapy that the patient's getting, unclear. My opinion is that maybe it's better suited for margin extension than in situ treatment. That's been our experience. That's not proven or supported by the bigger experience of Dr. Martin. And very clearly, I do not believe that this is a minimally invasive approach, nor do I consider RFA a minimally invasive approach. So in the interest of time, the real point is that survival depends on whether you maintain a complete response and don't get metastatic disease. The problem is we still have no way of selecting which patients are going to fall into that first category. And as such, we feel we should be much more aggressive in treating locally advanced pancreatic cancer in centers that really focus on treating locally advanced pancreatic cancer. And if the ablative technique is our method of moving toward getting that done, then that should be the case. Or if you want to proceed like the Heidelberg group and going right to it without this kind of escape route of ablation, no one's proven one technique to be better than the other. We need more study. Thank you.